Morning. We'll give it another 4 or 5 minutes, and we'll get 2 or 3 minutes, and we'll get going.
Mhm.
All right, I guess we'll get going, even though everyone's not here. Okay. So you're on call in the ICU, and you're reviewing your telemetry, and this is what you've identified. And question is asking, what is the likely mechanism for what the red arrow is pointing at? So I'm going to ask Dr. Condon what she thinks we're looking at here.
Morning. Well,
I
so
should tell you this is why don't we just, for the sake of conversation, say this is a 2-month-old.
yeah, so the majority of their heart rates are between around 150 and like 175 or so. So this could just be it could be artifact. But it also, I think the first thing that came to mind was like a sudden increase in the heart rate. For a 2-month-old, it could be ORT. Um,
What else could it be?
it could be ABNRT.
Right. So is this more likely representative of reentrant arrhythmia or an automatic tachycardia?
So it doesn't have like a what's it called? Like a warm up and cool down. So I think that's autonomic, or
No.
that's the reentrant? Okay.
So no, the automatic arrhythmias tend to warm up and cool down, right? And
Uh,
reentrant are like, what did your suggested etiologies are correct. Are those automatic or reentrant arrhythmias?
oh, those are reentrant.
Of course.
Yes.
So so the point of this tracing is simply to demonstrate that certainly artifact is always in the differential, and I didn't give you the x-axis, so you don't know what the time scale I'm looking at here is. If this was if this entire tracing was 5 minutes, then this could have been an artifact, but because that would have represented like 3 seconds. However, when you see a sudden onset and offset, as you do here, that alone will give you a very good idea regarding mechanism for tachycardia. And so this is another, sort of pearl, which is that you always want to look at the heart rate trend when you're looking at whether it's a monitor in the ICU or on the floor or in the NICU, or even when you're reviewing Holters. Whenever I look at our Zio patches, I'm always looking at the heart rate trend in order to see if there's anything important like this. This would be a worrisome finding, and I would hope that if this was a Zio patch, that they would provide for me the tracing of what happened at that time. Now, it could be an artifact, particularly if the leads were halfway attached to the patient and causing lots and lots of electrical artifact, but this looks very, very strongly like a reentrant arrhythmia. So, and in fact, in this case, this was a child who had SVT, and and interestingly, this was in a neonatal ICU. They did not actually know that the child was having SVT. We were in the hospital monitoring for SVT, and this episode was brief enough that it was not in real time identified by the staff and had to be identified on the tele. So this is one of the reasons why we always want to look at the telemetry and not always just accept what somebody said as the sign out that there was nothing happening overnight. Okay. All right. This is a 4-year-old who has a history of SVT, and patient has received 1 milligram per kilogram of IV adenosine, and this is the This is the tracing from the monitor. So what is happening, and what would you do about this? So I'm going to ask, why don't we ask Dr. Marshall what she thinks?
Good morning.
Good morning.
All right. So globally looking at it, you can see, looks like we give it at the beginning of the strip. And then there's one beat there that looks like a clear, like almost in the center of the screen. Like a
Talking about this
clear,
beat or this beat?
that, I mean, the QRS looks, those two beats, the QRS looks a little wide and the P wave is right before it. So I'm personally not sure if it is truly sinus conducted or if it's just that they're close enough, because to me the QRS morphology looks a little different.
Yep.
But then the beat, like, so whether it's like a ventricular escape and like the sinus, like they're just like coincidentally right next to each other. And then the beat after, though, to me looks most convincing for like a sinus beat.
Okay.
And then I think the 2 to 3 after are as well. But then you see him or her go back into SVT.
Okay. So you made a very important observation, Molly, about these beats. So I don't actually know what the mechanism is. Maybe someone can figure it out for me. Maybe it's already determined. But when you give adenosine to patients, it's not uncommon that you will, with termination, develop a couple of wide QRS beats. And so I agree with you. I don't know if this beat is conducted. It might be.
Right. Like I can't say for sure whether it is or isn't.
Because there's still probably some adenosine on board. Remember that although adenosine works predominantly at the AV node, it also does transiently cause sinus slowing, which is why the sinus rate is so slow here.
Yeah.
So it's possible it's conducting, and that because of the effect of the adenosine still on the AV conduction, that there's a bundle branch from, residual, adenosine. But it is just as possible, as you suggest, that these are then you used isosynchronous, that there's a sinus.
That's a nicer term.
There's a sinus P wave at the same time that there is a PVC. It's not really possible to tell if either of these are conducted. I think they probably are conducted, but I don't really know for sure. And then, as you rightly point out, the patient goes right back into tachycardia. Now, let me ask you this. Is there anything else any other comment you could make about the mechanism for the SVT? Could this be WPW based on these tracings?
I'm not, if you think that, I mean, looking at those two beats, like if we do think those are sinus, like you could, although the PR doesn't look that short to me for the age, but you could argue that those look like pre-excited potentially. If those two beats are in fact sinus.
Right. I mean, I think your point is correct, which is that the PR interval is not especially short.
Yeah, look, it doesn't, right, but yeah, because it doesn't like really meet the trifecta.
So this is one of the benefits, of having a strip, recording it while someone is being cardioverted in some way. Typically, if someone is pre-excited, let's say that they have intermittent pre-excitation, or maybe they have a left-sided accessory pathway that is challenging to identify the pre-excitation. And normally, if you give adenosine, of course, you're blocking the node transiently, and you should not be blocking the accessory pathway usually. So it's often a good way to tell if somebody has subtle pre-excitation is during those first couple of beats after a patient has received IV adenosine. But in this case, we do not have pre-excitation. So I would say this is unlikely to be a patient with WPW. Okay, so you've given 1 milligram per kilo of adenosine, and we now, unfortunately, the next PAC or PVC has clicked the patient back into tachycardia. What would you do?
You can do another dose.
Okay, so would you give the same dose, a different dose?
What did we say the dose? Oh, it's on there. I don't know how big the kid is, but because you can do only like a max number, but so whatever the kid's weight is, which I'm guessing is probably where you couldn't do bigger than that. It's
Right.
max 6, so I'm guessing the kid is right. Yeah, the kid's 4, so I'm
So
guessing the kid is bigger than
this is erroneous. It's actually 0.1 per
Mike.
kilo, but
Yeah,
whatever. Okay,
yeah.
so my question really I'm trying to hint at is there benefit to going to, normally when somebody has SVT and the dose is ineffective, right? The usual recommendation is to double the dose, right? At least after the first dose. So let's assume this is 0.1 per kilo. It looks as if it worked transiently, but we clearly went right back into tachycardia, as you explained. So should the next dose be 0.1 per kilo or should it be 0.2 per kilo?
I would do 0.2 per kilo then, as long as it stays under the max recommended dose.
Okay. I'm going to suggest that there's nothing wrong with that choice, but that's not what to do. And I'll tell you why. Because the truth is the 0.1 per kilo worked. It did terminate the tachycardia.
Right.
Just the patient went back in.
So
it wouldn't be wrong to give 0.2, but probably if 0.1 clearly worked, it's just unfortunate that the child went right back in.
Gotcha.
I'm sure you guys have seen when we do EP studies, sometimes we'll pace terminate SVT and it goes right back in, and we're saying try again, we're just pacing and pacing until it finally stops. Okay, so let's say, for the sake of conversation, you have given 0.2 per kilo, and exactly the same thing happens again. It does work, it breaks the tachycardia, but we go right back in. What would you do at this point?
And then the kids remain stable this whole time?
Yeah, the patient is stable. It's in the emergency department. Is crying. In 2023, doctors hate to see children in SVT. So it's a good question, because if this was Dr. Arnon in 1979, they would probably just give the patient an antiarrhythmic agent by mouth and just send them upstairs to the ICU and watch them. And eventually the patient would convert. This was in the really old days, they would give digoxin. They would digitalize the patient. And there's all kinds of rules that, different older doctors will tell you, when you're not giving enough, but they would digitalize the patient, and then they would just essentially park them in a corner, say, don't pay too much attention to them, and wait until the tachycardia terminated. But in 2023, we like immediate satisfaction. It's not acceptable answer to just leave them in SVT. So what could you do now? So now you're at higher level management. You've given the adenosine, hasn't worked. What else could you do?
So we've done our due diligence, not working. I think then you could start, and you have access because you've been giving them adenosine, but could start IV medication for them.
Yes. So what IV medicine would you consider?
You could do procainamide.
Right. You could give procainamide, sure. And do you remember the dose of procainamide?
You can do, it depends kind of which way you want to go about it, but you could do either initial bolus of like 10 to 20 per kilo up front, or you could do like smaller aliquots of like 5 per kilo over a shorter amount of time.
And then what would the drip rate be?
And then after, I think we usually start around like 20 or so mics per kilo per minute.
Right. We usually start at 20. You can go as high as 40. And then, okay, so that works. Tachycardia breaks. How do you propose to medically manage this patient? Because let's say Dr. Pass and Dr. Love are out of town, not able to do an ablation on this 4-year-old who's having so much trouble. So you have to send this kid home on medication. How would you transition? Would you start oral procainamide since it seemed to work so well?
No, I'd likely do like something like propranolol.
Right, you could use propranolol, or really could use
do amio, or
you could use amiodarone, although the problem with amio, of course, is that it has a lot of side effects,
right?
Albeit very rarely in short-term use. And if let's say you decide you're going to do an ablation in, let's say, 6 months, but you then, the half-life is so long of amio that you have to sort of stop it 3 months in advance of the ablation.
Yeah.
The patient is in some weird location, weird place in terms of treated but not treated. So you could start propranolol, you could give sotalol, you could give flecainide, you could even give verapamil, calcium channel blocker. Now, in terms of acute agents, let's say the emergency room doctor says, I don't feel comfortable with procainamide. I haven't used that since 1989. Do you have any other options for me for IV therapy?
I mean, you could do amiodarone, but I think we kind of talk about there's like I mean, this kid's older, so it's not
Right.
like it's like a newborn baby, but we talk about like the risk of cardiovascular collapse. So you could do amiodarone, you could do
Yeah.
like esmolol if
Mhm.
available, like IV beta blocker options if available.
Yeah, no, you could do either of those. And, the risk for cardiovascular collapse is profoundly lower in a 4-year-old than a baby. I'm not sure. I mean, I'm sure everything has happened somewhere, but honestly, for me, the main reason I wouldn't use IV amio in a 4-year-old would not be so much that I'd worry about cardiovascular collapse. That really doesn't happen in that age unless you give a toxic dose. Honestly, what would be more worrying to me is the possibility of a chemical burn from amio. Amio is
Yeah.
extremely bad, causes phlebitis and then extravasation, and I've seen a handful of chemical burns in children. It's amazing. You can stop a life-threatening arrhythmia in a patient, and their parents still hate you if they end up needing a skin graft to their arm. So
That's what they'll remember.
yeah. So again, I want to be very clear. If someone's dying and is in very bad shape, you give the amio IV, get control of the rhythm, then you figure out whether you need a better line. So you don't not give it ever if you think you definitely need it. But that should always be in the back of your mind. And I always say, to the staff, do you have a good IV? Because one needs to keep very careful attention to the IV when you're giving IV amio. In fact, in the large multi-center randomized controlled trial that Phil Saul did, and which I recently learned I'm a co-author on, even though I never enrolled a single patient, that study, there was like a 40% incidence of serious complications, and like 10% of them were, chemical burns from amio. So generally good drug in the ICU where you have central venous access. And again, I want to be clear. If someone's dying, is an emergency, you give IV amio. Do not give it because you're worried you're going to get a chemical burn. But it's a concern. The other thing you could try is IV sotalol, which we do actually have on formulary now at Sinai. We just haven't really used it very much, and right now it's restricted to only, I think, me and Barry have to either be there or approve it or something like that, but we haven't used it yet. So
is there any time that you would prefer to use that?
Well, I guess the truth is we need to develop a higher degree of comfort with it. My attitude about it is I haven't yet really found any evidence that it's so much better than the other agents that exist. Ellis Rochelson wrote a paper, and we even had him on the podcast maybe a year or two ago, from Texas Children's, showing that it seemed to work very well, and particularly for the treatment of JET, they felt that I think they thought it worked a little faster than IV amio or procainamide, and was not associated with cardiovascular collapse or as much hemodynamic instability. So that might be a potential role for that agent. And one of the benefits of it in theory is, like, if you wanted to start the patient on oral sotalol, you actually can just essentially switch the IV to oral almost immediately because the half-life is short, and then the patient is basically on the agent quicker. So we probably should start to try to use it just to get some familiarity with it, but we haven't yet. But I'm sure at some point we'll have somebody who has a hard to treat arrhythmia and give it a shot. So, okay, good job. Thank you. All right. You're in your office and you're asked to evaluate a teenager who has recurrent syncope. And this is the patient's electrocardiogram. So I'm going to ask, let me ask Dr. Bezdakova what she thinks about this tracing and whether she would do anything about this or.
Good morning, Dr. Pass.
Good morning.
So looking at this EKG, initially looking at the rate and, sorry, what's the age of this patient? Oh, it's a teenager. So the heart rate of about, say, 65, which would be normal a rate to bradycardia for this age group. And then looking at all of the leads, there is a P wave before every QRS, so I would say sinus bradycardia. However, the looking at the T wave, it looks flattened in some leads, and then as well as prolonged. When you just freehand, you look at it, the QT interval is about the same to a little bit more of the preceding R to R. And so, with syncope and concern for prolonged QT, I would be concerned that, this patient has this, and, maybe there was an arrhythmia that preceded the syncope and causes syncope. So I would have the patient on a Holter monitor, to get a better look at how their rhythm is over 48 hours.
So what are you looking for on the Zio or a Holter? Why would you place one? I agree with you. I would do that as part of an evaluation. What are you do patients with long QT syndrome, are they usually having arrhythmias or usually not having arrhythmias most of their life?
Usually not having arrhythmias.
Right. The first episode of arrhythmia could be sudden death in some, and that could happen at any age. So yes, certainly if you put a Holter on a patient and they had lots of arrhythmia, that would be very helpful. But we're not usually that lucky. But there is another good reason. So I agree 100% with you that I would definitely do a Holter in this patient. But so that would be one reason, just to see, are they having arrhythmia? But is there anything else that we might glean from a monitor in someone in whom we are concerned about long QT syndrome?
You could also be looking for pre-excitation on the monitor as well.
Well, yeah, you could look for pre-excitation, but I mean, you have this electrocardiogram where you are worried about repolarization, not so much depolarization. But yes, this certainly people can have intermittent pre-excitation, but that would be very unlucky, right, to have a long QT interval and also, by the way, have WPW. Not saying it couldn't happen, but it seems unlikely that one person would get so unlucky. So again, just to reemphasize what Christina said, the QT interval is long. That's important. And then secondly, although not super long, if you correct it, I think these numbers are actually fairly accurate, that the QTC is about 480. But the other thing about it is the T wave looks strange. And this is why looking at lots and lots of electrocardiograms is useful. It's sort of like how you become an AI model yourself. Look here in lead 3, you have an inverted T wave, which we do rarely see in healthy patients, but this is a little unusual. It's a very long, sorry about that. A very long isoelectric period, right? Very late peaking T wave. Look how you see the T wave all the way over there. AVF with this very flat T wave. The fact that we have this somewhat juvenile pattern with inverted T waves in V3 and V2, that might be normal. I haven't given you the exact age of the patient. I would feel differently if this was a 18-year-old versus a 13-year-old. But even here, we see this sort of very late peaking pointy T wave. So even if the QT interval were normal in this patient, I would be somewhat concerned. So, a lot of people think that if you're under 500, it's not a guarantee that it is long QT, but the morphology of these T waves is very abnormal. And so when you see that, you need to think in your mind as to whether you are in fact seeing a tracing. So the other thing that you would want to know on a Zeo patch is whether you're seeing the phenomenon of T wave alternans, where there is a beat to beat changing in the morphology or even the axis of the T waves, which can be a sign that precedes an onset of ventricular arrhythmia or channel instability. So I'm always looking for that when I'm looking at tracings of people who have long QT. Now, most of the time, the reason that we get Zeos on people that we think have long QT is because we're assessing beta blocker efficacy. We want to make sure that remember that beta blockers as a side effect cause sinus bradycardia. And so we do want to keep an eye on the heart rate as a good indirect sign that we're on a good dose of medication. And I will remind that it is not the bradycardia that beta blockers cause that causes protection from arrhythmias in long QT syndrome. It is simply a side effect that we observe that we assume is a sign that you're on a decent dose of beta blockade. If you have a blunted heart rate response on the Zeo or the Holter, that's usually a good sign that you are on a decent dose of medication. Typically, you need about 2 per kilo of most beta blockers to achieve that at least. Anything you want to know about that? What would you ask the family? So you see this EKG, it's somewhat concerning. What do you want to know about the history of the patient in regards to these episodes? And then what other questions would you ask the parents of this child?
So in regards to the patient, I would ask them if they had any prior episodes of syncope besides this episode, and I would ask about the nature of the syncope, if it was,
What do you want to know about it? Yeah, go ahead.
If it, when the patient had this episode, if it came on where, they felt faint and dizzy, or if it was just a sudden onset of syncope where they just, don't really remember anything immediately prior.
Well, the suddenness or the non-suddenness could be from almost anything. Is there any particular symptom prior to the syncope that would be more worrisome for arrhythmia as an etiology?
Like chest pain or palpitation?
Yeah, definitely. Some patients will definitely tell you, no, my heart was racing, and next thing I knew, I woke up. So palpitations. What about the circumstances of the episode? Is there anything that would be more suggestive of long QT versus others?
Would it be more suggestive if they were exercising versus
Yes.
at rest?
Yes, that's correct. So anytime somebody complains of syncope with exertion, that is a very worrisome finding. You should always evaluate that aggressively because that is not a normal response to exercise. You have to, and this is why getting a history is very important, because it's not uncommon that people have neurocardiogenic syncope after exercise. So typical story is, I was playing basketball. This girl is on the high school basketball team. She's just played 3/4 of the game. She was feeling tired. She, sat down on the side, and then when she stood up, she felt faint and went down. And in that case, we would think it's more likely neurocardiogenic. Maybe the patient was somewhat dehydrated because she was playing for an hour in the game very hard, wasn't adequately hydrating, stood up, felt faint, and passed out, as opposed to is literally, taking a run towards the basket and goes down in mid-flight. She's literally got her arm up and is about to let go of the ball, and she goes down. That would be a much more worrisome finding, and almost always is cardiac in nature and not neurocardiogenic. So yeah, that would be very important. What about family history?
And then I would ask if there's any family history of sudden cardiac death before, at a younger age, before the age of 50, and there are any drownings, or the patient, or if a family member was driving and had a cardiac event.
Yeah, so that's right. So you want to ask very carefully if there's any history of sudden cardiac death. And I would actually say under 40, okay? Because 40 to 50 people with hyperlipidemias can have heart attacks with some, I think at that point, a heart attack is more likely going to be due to an actual coronary issue. But yes, you're going to want to ask those questions, because it's not uncommon that you find out that, yes, in fact, there is a family history of this, and oftentimes families don't put it together. Like there may be some story that is like Uncle Joe, was 32. I never met him, but he died. He had a heart attack. And then you find out that Uncle Joe was 32, and you're thinking to yourself, why would a 32-year-old have a heart attack from coronary artery disease? And then you find out that, they don't know a lot about Uncle Joe, but this is like a family story that they've heard for many years. So then the next step would be to do electrocardiograms on the parents, right? See if if either of them have it. You want to get a very detailed history of both parents and whether they've had syncope or palpitations, whether they've had electrocardiograms, and you want to review them. So sometimes a parent will say to me, I had an EKG in the past, and I was told it was normal. You still want to see that EKG, because a lot of times in the adult cardiology world, in my experience, they will they pass an EKG if they don't see evidence for ischemia, but they don't necessarily 100% of the time look at the QT interval. I once had a patient years ago, very tragic story, where a patient died when hearing a very loud noise. And then when they did electrocardiograms on siblings of this patient, were identified to have long QT intervals, both siblings. And then in retrospect, one of the parents of this patient had been seen in an emergency room 6 months earlier with some chest pain, which was determined to be GE reflux. But on that electrocardiogram, there was clear evidence for a long QT interval. And in retrospect, if the adult physician had identified or noticed that the QT was long, of course, the correct step then would have been to screen all of that individual's children for a long QT interval. And perhaps, in theory, the patient could have been treated, and who knows what would have happened. Maybe it would have had a different outcome. So you do want to always ask if you can see the tracings of the parents of this patient. And then finally, and if there's siblings, you might want to do siblings. And then finally, you would want a genetic evaluation, because approximately in 2023, something on the range of 75 to 80% of children who have long QT syndrome will have a positive genetic test. And that would be very, very useful information in terms of ruling in or ruling out other family members. And it also would be helpful in terms of prognosis, because we know that certain types of long QT are more or less effectively treated with beta blockers. And there are also certain additional precautions with certain forms of long QT you would want to know about. So it would be helpful. Any questions about this? All right.
Can I ask one brief one in general? So, I mean, this one, like, for the reasons you guys talked about, the T waves, and there is, although not super long, prolonged QT, but and it being recurrent, there's a lot of things in this patient that are concerning for long QT, but we've also talked about in like some journal clubs and things, and have seen where kids who even have like vasovagal syncope can have like slightly prolonged QT.
Yeah.
My question is, like, I would assume that the T wave morphology is not as abnormal in those kids, but even when you're seeing a kid, like, you get referred in the office, I'm sure, for this, and like you find that it's not, but if you were the fellow on call in the ED, like, would you recommend I guess my thought would be to recommend them getting an EKG at some point when they haven't had the episode to ensure that it's fine, or kind of how would you approach that?
Right. So that's a very, very good point you're raising, Molly, which is that people with neurocardiogenic syncope can have, around the time of the episode, a longer QT. So you would definitely want to see the QT at different times. I would not make the diagnosis of long QT syndrome just on this electrocardiogram. I would want to see it at different times. I would want to see what the Zio or the Holter monitor look like. And the other test that we haven't discussed is I would definitely do a stress test on this patient because traditionally people who have long QT, so normally when we exercise, repolarization will shorten with enhanced adrenergic tone. Most patients who have long QT syndrome, the QT will either not shorten or may even lengthen with exercise. So there are also other tests where they have people hyperventilate, or sometimes they'll do EKGs quickly standing up. I'll send you all this article I read a few months ago on all of these different tricks that you can do. Some people will even give a dose of IV of epinephrine, which I would not do. I think that's very dangerous. But some people have advocated that. But yeah, I would do some more provocative testing. Sure, this is a gray ECG. This is one where if I met the patient for the first time in the office, unless they gave me a very interesting story of like I was running, I had palpitations, I felt my heart was racing, and then I went down, I would probably not call this long QT yet. I would want to see more tracings, get a family history, do all of these other tests that are confirmatory or may go against that diagnosis, or I would make that call. Now, there are some patients where the QT is obviously very long. I don't, for example, think that people with neurocardiogenic syncope have QT intervals that go out to 500 milliseconds.
Right. It's usually borderline. Yeah.
Right. Exactly. And sometimes it's very, very obvious, but when it's not obvious, I agree with you. You do have to do more of, because you have to be cognizant of the fact that once we make that diagnosis, this has a massive impact on the entire rest of the life of this patient. So you really want to be pretty darn sure. And this is one of the reasons why when we have a patient who does not have positive genetics, it always leaves a weird taste in your mouth as the doctor, because you feel a little uncomfortable making that diagnosis in patients who don't have a positive genetic test. Now, in the present era where we have become a little more liberal about activities in people with long QT, we can sometimes take in between approaches and say, well, we think that there may be some instability to your repolarization possible. Make sure you avoid agents that can prolong the QT, which you can get from the website crediblemeds.org. Be aware of the risks with exertion, have an AED at courtside, but we wouldn't make any more strong recommendations than that at this time. The other thing to remember is that genetic information and knowledge changes with time, and both in cardiomyopathy as well as a lot of arrhythmogenic conditions, the number of genes that we now know are associated with these conditions is massively changed in just a few years. When I started my career finishing fellowship, there were 3 genes that were known for the cause of long QT syndrome. Today, I believe there are either 15 or 18 of these. So same thing with cardiomyopathy. I remember earlier in my career thinking it was so stupid. Why would we do genetic testing on hypertropes or whatever? Well, it turns out they now can actually identify a lot of genes, and they have a lot of information about some of these genes, what to expect or not to expect. So when you have a patient who has a genetic condition, but you don't have positive genetics, it's always worthwhile checking in with the geneticist every 5 or 10 years, because somebody who is quote unquote negative by standards of 10 years ago may very well now be positive. So it's an important point. So, all right, guys, I think we'll stop here. I appreciate your time. Hope you all have a great day, and I'll see you in Sinai in a little while.
Thank you.
Thank you.